Good morning. My name is Dr. Moinak Sarma, and I am Assistant Professor in the Department of Pediatric Gastroenterology in Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And today I'll be dealing with the approach to chronic liver diseases in children. So as you know, children have a different spectrum of etiology as compared to adults. We have biliary diseases, we have intrahepatic diseases, and we have metabolic diseases. Among the biliary diseases, that means those that affect the liver outside the liver from the biliary system, are diseases like biliary atresia, choledochal cysts, sclerosing cholangitis, progressive familial intrahepatic cholestasis, PILBD, which is paucity of interlobular bile ducts, allegedly syndrome, and bile acid synthetic defects. There are some diseases which affect the sinusoids of the liver, and those are the intrahepatic causes. And namely, those are Wilson's disease, autoimmune liver disease, hepatitis B, C, Budd-Chiari syndrome, which is a post-sinusoidal disorder, congenital hepatic fibrosis, storage diseases like Niemann-Pick and Gaucher's, and NASH or NAFLD, which is non-alcoholic fatty liver disease. Metabolic diseases like tyrosinemia, galactosemia, hereditary fructose intolerance, and congenital disorders of glycosylation are those diseases that are uniquely associated in children. Indian childhood cirrhosis was there in the past, but for some reasons it has decreasing trend. If you look at infants and younger children and older children more than 5 years of age, the adolescents, there are two different spectrums. The younger age groups are mostly affected by biliary atresia, choledochal cyst, PFIC, allegedly galactosemia, tyrosinemia, and glycogen storage disorders. Those who are older, and these are adolescents and children who are more than 5 years of age, autoimmune liver disease, Wilson's, hepatitis B, sclerosing cholangitis, tyrosinemia, allegedly, progressive familial intrahepatic cholestasis type 3, type 1 and 2 for younger children, Niemann-Pick disease, glycogen storage disorders, and non-alcoholic fatty liver disease are the important etiology. But these are not compartmentalized. They may be overlap between the age groups. So how do you suspect a chronic liver disease? So you have two types of suspicion. One is a clinical suspicion and the other is on investigation. So if you look at clinical suspicion, there will be some features which are common to all disorders, and then there will be a few signs and symptoms which are etiology specific. So those which are common to all disorders are physical features of the liver. That means we talk about hard liver, firm liver, irregular liver, nodular liver, things like that. Evidence of portal hypertension in the form of splenomegaly, ascites, dilated veins, varices. Stigmata of chronic liver disease, and I'll be talking about those very soon, and features of decompensation, that means ascites, encephalopathy, variceal bleed. Sometimes you may have a situation where the child is more or less asymptomatic. They might not be overt features clinically, but on investigation you have a doubt. That means there is a low albumin coagulopathy that suggests the synthetic functions of the liver is affected. Varices on endoscopy, dilated portal vein on an ultrasound, abdominal collaterals that are seen on ultrasound. So if you look at clinical features of chronic liver disease, you may have florid presentation of chronicity. That means a decompensated liver disease. So here there is no doubt. Patient presents as ascites, encephalopathy, bleed. This is florid presentation. You may have a subtle presentation of a small duration or a long duration, but clinical features of chronicity. That means child has not really come with mild jaundice maybe, but he has an irregular liver on examination. Or the presentation may be an acute presentation at an onset, and there may be an underlying chronic liver disease. If you look at the first presentation, which is the florid manifestation, this is usually a long duration of jaundice, maybe more than 6 months, ascites, recurrent encephalopathy, variceal bleed, a combination of all or most of them. There is no ambiguity. This is a compensated liver disease. And when you look at series that have looked at clinical features of children with cirrhosis, you've seen that most of the children usually present by the age of 8 years, and most have, at the time of presentation, they have splenomegaly, jaundice in more than 3/4 of the population of the cirrhotics. 50% may have ascites, 30% have encephalopathy. The duration of jaundice, to say that this is a chronic liver disease, is not compartmentalized to any duration of months. It is not necessary to have 6 months of jaundice to call it chronic liver disease. There may be features of chronic liver disease, but the symptom duration may be very, very little, as low as 3 months in 60% of the cases. Second is subtle features. That means you have a jaundice which may be mild or of a short duration, but you may have had transient ascites that have come and gone, altered sensorium that has come and gone, and you are doubtful that there is an underlying CLD. What should you look for in the examination? Very important is a sharp irregular liver. Leafy livers, they say in Indian child with cirrhosis specifically, or a Mangalore tile liver in Indian child with cirrhosis. But otherwise, most of the cirrhotics have a sharp irregular liver. The surface may be nodular, and a nodular surface tells you there is a macronodular cirrhosis. Classical example is hepatitis B. The liver may be hard in congenital hepatic fibrosis or firm, but firm is not specific for chronic liver disease. It may be present in an acute viral hepatitis also. If the liver span is shrunken, it is specific for cirrhosis. It may be present in acute liver failure, but an enlarged liver may be seen in a secondary biliary cirrhosis, cholestatic diseases, and storage disorders. Differential enlargement, if you have, is suggestive. That means the left lobe is larger than the right lobe. These are the features of portal hypertension. As you can see, this is a child with ascites. Then the next picture shows you dilated veins, and then the picture on the top tells you that there is an irregular liver and a spleen that is palpable. So the evidence of portal hypertension in a chronic liver disease is upper gastrointestinal bleeding, ascites, splenomegaly, collaterals, and on investigations, you may find varices, or imaging may show dilated portal vein or anything that is specific of portal hypertension. What are the stigmata of CLD? Now, the stigmata of CLD has originally started from the adult cirrhotics who were mostly alcoholic, and they had varied signs to say on peripheral examination that they have chronic liver disease. We don't find so many stigmata in children, and our children are not alcoholic. So all the florid features of CLD that you read in books will not be present in children. The first and foremost is the Palmer erythema. Please remember, Palmer erythema is physiological till the first 2 years of life. Thereafterwards, if you see Palmer erythema, it may be suggestive of a chronic liver disease. White nails, clubbing, Merkey's nail, half and half nail, these are all features to tell you that there is a chronic liver disease, and a half and half nail is suggestive of chronic hypoalbuminemia. Spider nevi, that means this is a small elevated pinpoint papule that is present in the territory of the superior vena cava. That means the face, the back, the trunk, and the neck. You take the head of a pin and press it on the tip of the pout, and you will see spider-like legs arising away from that point, centripetal. So this is called spider nevi, and various books say that more than 5 in the superior vena cava territory is considered abnormal. But in children, we don't see this cutoff figure of 5, even 1 or 2. If you see and you have features of an irregular liver, this is spider nevi. You cannot ignore even 1 or 2 spider nevi. Gynecomastia, usually you are going to expect it in a prepubertal child who has cirrhosis. In puberty, remember, gynecomastia may be a normal phenomenon, so it cannot be uh, called as sine qua non of cirrhosis. And it is also important to remember that drugs like spironolactone can also give rise to breast enlargement. So physiological gynecomastia in puberty and drug-induced gynecomastia are some of the other reasons for gynecomastia other than liver disease. Then there are other physical features such as Bitot spots, because you have to remember that chronic liver disease will also lead to the fat-soluble vitamin deficiency. There is not enough bile that is there in the circulation for them to absorb all the multivitamins, the vitamin A, D, E, and K. Hence, consequently, you will get features of the same. There is another reason. The vitamin A is stored in the ito cells of the liver. If the liver undergoes necrosis, these liver cells are lost, vitamin A is lost, hence the patient, as you can see, has Bitot spots. Because of vitamin D deficiency, the patients may have hepatotrophic osteodystrophy that may present as rickets. But there are some diseases that present cirrhotics that present with rickets, such as tyrosinemia, because of a renal tubular acidosis. Then you have specific features like Alagille syndrome, which has Alagille faces. This is a broad forehead, sharp pointed chin, sharp pointed nose, and this is typical of Alagille syndrome. Then you have some important features like KF ring that may be seen, the Kayser-Fleischer ring that may be seen on naked eye or on slit lamp examination in Wilson's disease. There are some other features also. For example, autoimmune liver disease has autoimmune skin manifestations like vitiligo, like leukoderma, psoriasis. Okay, these are acne. These are features in autoimmune liver disease, and there may be also features that may suggest hepatitis C in adults. It is known to cause various kinds of skin manifestations. In hepatitis B, during the seroconversion, you may have acropapular dermatitis, which is called as Giannotti-Crosty syndrome, but that is not a cirrhotic condition. Then you have pruritus, that may be the third manifestation. So a long-standing, early onset, intractable familial pruritus may be suggestive of an underlying chronic liver disease. Patients usually have jaundice conjugated, which is persistent or recurrent, and they have xanthomas, xanthelasmas, they have shiny nails, and they have a lot of dermatitis, which is very similar to the elephant type of skin, thickening of the skin, and this is very specific of pruritus due to constant scratching. The fifth presentation is if you have a conglomeration of various other features such as family history of chronic liver disease, obesity, systemic features like rash, joint pains, and acne, or a multi-transfused patient. If all this is present in a liver disease condition with elevated liver enzyme and hepatosplenomegaly, then your diagnosis of chronic liver disease or cirrhosis is quite likely. The sixth presentation is an asymptomatic presentation. Patient has not had any symptoms, but for some other reason is gone to the doctor and he's had asymptomatic elevation of transaminases, alkaline phosphatase, or gamma glutarate transferase. And on examination, he has hepatosplenomegaly or a shrunken liver, and this is most likely a chronic liver disease going on. How do I proceed? The first step is to do a complete liver function test, including gamma glutamyl transferase. You see, GGT is a very important investigation in the LFT because GGT elevation suggests that there is a biliary block somewhere, a biliary pathology going on. Conversely, a very low GGT can also be found in conditions such as progressive familial intrahepatic cholestasis. And you need a hemogram. The hemogram will tell you whether there are features of hypersplenism or any other issue. So if you have transaminases, that means liver enzymes, SGOT, SGPT, or ASTLT as you like to call it, 2 to 3 times more than the upper limit of normal, with or without any abnormality, then you have a few possibilities. You may be having a concurrent illness or an infection that has caused this transaminases to be elevated. You might have taken a hepatotoxic drug that has caused this transaminase elevation. You might have been transfused or had an acute viral hepatitis or a cardiac disease, and that has caused. In the absence of all these 5 things, if you still have transaminases which are elevated, then this may be a clue to a chronic liver disease. If you document its persistence for more than 3 months, that means you've repeated the LFT multiple times and confirmed that yes, transaminases are elevated, then you are most likely dealing with a chronic liver disease. So transaminase is elevated, hepatosplenomegaly, splenomegaly. The next step is to do an ultrasonography hepatobiliary. Now, it is very important for you to remember that in the ultrasonography, there are few things that are very, very important. The liver status, that means how is the margin, what is its surface, is it nodular or not, is an important feature. Whether the biliary system is normal and abnormal is important. What are the veins like inside the liver? Are they blocked? Are they patent? Can they be suggestive of Budd-Chiari syndrome? Very, very important. What is the diameter of the portal vein? These are the things that you have to note down in ultrasonography. Once you have fairly been sure that there is something on biochemistry and ultrasonography that is suggestive of chronic liver disease, you proceed as per the etiology. And in children, these are the most common etiology you have to look through: hepatitis B, C, ceruloplasmin, 24-hour urinary copper, Kaiser-Fleischer ring, autoimmune antibodies, ANA, anti-nuclear antibodies, SMA, which is smooth muscle antibody, LKM, which is liver, kidney, microsomal antibody, immunoglobulin G, and a lipid profile if there is an obesity going on. Next, you do a liver biopsy. That is not mandatory in all cases, but it is preferable because number one, it may aid in the diagnosis, and number two, it may also tell you the prognosis. And already cirrhotic liver is not going to do too well as compared to that which does not have florid cirrhosis in it. You can do the liver biopsy percutaneous, but if you have coagulopathy, if you have very low platelet count due to hypersplenism, or if you have ascites which cannot cause tamponade effect after liver biopsy, then you will need to do a liver biopsy which is not percutaneous but through the transjugular route. That means through the neck into the liver. So even if it bleeds into the blood vessels. Otherwise, percutaneous liver biopsy in a cirrhotic who has coagulopathy or thrombocytopenia carries the risk of hemorrhage. Liver biopsy is not required in all scenarios. It may be considered in a case-to-case basis. And if you really want to document fibrosis, you can also do it by transient elastography. Now, the workup for portal hypertension, as I have said in the previous slide, hemogram for hypersplenism, liver function test including prothrombin time, which is very, very, very important. Doppler ultrasonography for portal vein cavernoma, the patency of the superior mesenteric vein, splenic vein, inferior mesenteric vein, and the left renal vein. This is important for those patients who have an additional extrahepatic portal hypertension and you would like to shunt or not shunt. Portal vein diameter, hepatic veins, and the IVC patency, which is very important in Budd-Chiari syndrome. Changes of cirrhosis in the liver, changes in the biliary tract, upper GI endoscopy for varices, and specific investigations of the underlying etiology. Now, what does liver function tell you? Now, liver function tests, hypoalbuminemia and coagulopathy indicate poor liver synthetic functions. An ultrasound Doppler, as I have told you, liver margin for irregularity, surface nodularity, caudate lobe hypertrophy, dilated portal vein with a hepatofugal flow, and the normal portal vein diameters are given below. In adults, a portal vein diameter of more than 13 mm is suggestive of intrahepatic portal hypertension. Hepatic veins and inferior vena cava block in Budd-Chiari syndrome, intrahepatic cholestasis, and post-parenchyma, which is may be present in cirrhosis, but it is not a definite evidence of cirrhosis. Transient elastography, which is also known as fibroscan, this is a non-invasive measurement of the degree of fibrosis. It is not required in all cases. Liver biopsy, as I have told you, percutaneous or transjugular. In that, what we look at is the loss of architecture, bands of fibrosis, nodule formation, and you have to do the reticulin stain or the mesenteric stain, which will outline fibrosis. Then there may be special features to underline the which will be specific to the underlying conditions, such as interface hepatitis in autoimmune liver disease, rosetting in autoimmune liver disease, or the hepatic amount of hepatic copper in case of Wilson's disease, the amount of liver glycogen in glycogen storage disease, or you may find infiltration with various storage cell that might suggest a storage disorder. This is the histology in chronic hepatitis. As you can see that this on the left hand side is normal and on the right hand side is a chronic hepatitis. You can see how the infiltrates have invaded into the from the porta into the hepatic parenchyma. These are nodule formations, very classical, round areas. There is loss of liver architecture and fibrosis formation. Now here I am going to give you a few examples to make you understand what I have just said. This is an 8-year-old girl who has presented with jaundice of 6 months duration, ascites of 4 months duration, GI bleed followed by encephalopathy, and she has recovered. Any doubt that the presentation can be chronic liver disease? No, it's very straightforward. Jaundice, ascites, variceal bleed, encephalopathy. And on examination, as you can see, there is a sharp, irregular, firm liver, and there is a spleen, and there are dilated, tortuous veins that are flowing upwards. There is free fluid. So there is nothing in this case that is going to take you away from chronic liver disease. Investigations show hypersplenism, that is hemoglobin 9.5, platelet count is 77,000. But since she has had a recent history of a GI bleed, we may not really conclude hypersplenism. We need to say hypersplenism only 3 months after the last bleed. Albumin is low, 2.9, AST/ALT is high, coagulopathy is there, INR is 2.3. The liver outline is irregular, nodular, portal vein is dilated, upper GI is showing large varices, and biopsy is showing interface hepatitis. This was a case of autoimmune liver disease, and in this patient, the LKM titer was raised 4 positive with 1 in 80 titers. This is a 9-year-old girl. Now this girl has presented with ascites progressive for the last 5 months. This is a large volume paracentesis has been done many times. 4 liters has been taken out, and she's rapidly reaccumulating. That means you take out fluid, she goes on accumulating fluid. If you see on examination, she has a sharp, big liver and dilated tortuous veins over the abdomen as well as back with tense ascites. The diagnosis here is pretty straightforward. If you look at the hepatic veins on the Doppler, you will see that the right, middle, and left are blocked at the ostia. The intrahepatic part is narrowed. This is a case of hepatic vein outflow obstruction, or better known as Budd-Chiari syndrome. The back veins suggest that the lumbar veins are trying to bypass that block and enter the systemic circulation through the surface veins over the back. Right? So this is Budd-Chiari syndrome. 4-year-old boy incidentally detected hepatomegaly at 1.5 years of age. The father, the paternal uncle in the family has had chronic renal failure. This child himself has had hematemesis 1 month back. That means there might have been a variceal bleed, and there is a sharp form irregular liver with a small spleen. The kidneys are not palpable. If you look at the investigation, the alkaline phosphatase is quite high. There are small cysts in both kidneys. There are large varices, and the liver biopsy is showing bile ductular proliferation, ductal plate malformation, and fibrosis. The diagnosis here is congenital hepatic fibrosis with polycystic kidney disease. Now, strictly speaking, congenital hepatic fibrosis is not a chronic liver disease or a cirrhosis, but we put it under this category because it is a very, very close differential diagnosis, and some small percentage of congenital hepatic fibrosis can actually behave like chronic liver disease in the years to come. So that is why chronic congenital hepatic fibrosis is a very important close differential diagnosis of cirrhosis in children. Now, this is a 6-year-old boy. In 2004, he had unexplained fever. He was on ATT. In October 2004, he had jaundice with a prodrome, ATT stopped, coagulopathy, altered sensorium. Maybe all of it was drug-induced, but we don't know. He was referred to our center with grade 3 encephalopathy, reduced liver span, and an INR of 6.5, clearly telling you that he was in liver failure. If you look at the workup, then the viral hepatitis acute viral markers were negative, but this patient had a KF ring, ceruloplasmin which was low, urinary copper which was high, and hence your diagnosis is Wilson's disease. What happens in hepatitis B? Well, there are two sorts of hepatitis B. One is the acute, which we will not be talking about, and that is because of a close contact, blood transfusion, barber shop, circumcision, and various things. And the other is chronic hepatitis B, and in children, the most common cause is the vertical transmission from the mother to the child. And if you have that sort of a phenomenon, then the chances of being chronically infected is 90%. It reduces if the exposure time has come at a different age. So if you have been exposed between 1 to 5 years, the chronicity chances are 50%. And if it is beyond 5 years of age, the chronicity chances are 5 to 10%. Now, the other reasons why chronic hepatitis B can prevail is because of horizontal transmission, transfusion, dialysis, IV drug abusers, sexual intercourse, and things like that. Most of the time, acute patients may clear in a few months, but some of them can die. If they don't clear, then a majority of it may be pushed to a chronic liver disease. Hepatitis C infection, you have to remember, both for hepatitis B and C, it takes years to get cirrhosis. In hepatitis C, it takes about 20 years to develop cirrhosis from the time of infection. Most common is vertical mother to child. Then you have blood, you have IV drug abuses, needle stick injuries, and things like that. If you are incidentally detected, then 70% chances you will develop chronicity. Acute is very rare. Chronic is common in adults. In children, chronic hepatitis C is a slightly uncommon, and it takes about 20 years to develop cirrhosis. There are wonder drugs available in hepatitis C these days, which allows you to clear hepatitis C very quickly. Now let's see one more case. This is a 10-year-old boy who presented with jaundice prodrome and ascites, and the duration between jaundice to ascites was 2 weeks duration. There was melena, there were diuretics that were given, paracentesis was done, and when we saw this patient, he had features of chronic CLD, a chronic liver disease, which is bite spots, clubbing, and an irregular liver. Now, I would like to look at this case slightly differently. You had two issues going on. One is on history, you had jaundice with a prodrome, short duration, which was resolving. Possibly you were dealing with an acute viral hepatitis. But at the same time, you had features of underlying CLD. That means you had history of ascites, which was early onset, upper GI bleed, which may have been because of variceal or coagulopathy, vitamin A deficiency, clubbing, persisting pedal edema despite the diuretics, irregular margin of the liver, moderate splenomegaly, and free fluid. If you look at the workup, hepatitis A was positive, but at the same time, workup for chronic liver disease, the ANA was 3+, SMA was 3+, immunoglobulins were very high, so you were dealing with an acute on chronic liver disease. How do we approach ascites in a chronic liver disease? You have various categories. The first one is an early onset. That means jaundice to ascites less than 4 weeks. A short history with a prodrome, quick response to diuretics, no telltale evidence of chronic liver disease. You may diagnose this case as an ascitic variant of acute viral hepatitis, which is very prevalent, in younger children. The other type is you have a short history of jaundice, but you have an evidence of CLD, maybe in the form of upper GI bleed or encephalopathy. So this is a decompensated CLD. Then you have an AVH-like episode which is superimposed to this early onset of jaundice, and as I've shown you in the previous slide, an acute and chronic liver disease. If the jaundice to ascites is more than 4 weeks of duration, that means late onset, the history is suggestive of acute viral hepatitis. There is a smoldering course, coagulopathy, no evidence of chronic liver disease, then you may think of a subacute hepatic failure. But in this scenario, ruling out a chronic liver disease is essential, imperative, and only time can tell you in follow-up whether this was a subacute hepatic failure. This is a gray area, a gray zone diagnosis, so we don't want to concentrate much on this. In summary, if you want to look at the clinical differences, and here I am going to include EHPVO also, because EHPVO is a close differential diagnosis of cirrhosis and you might easily get confused. You have in EHO mostly GI bleed, which is well tolerated. That means the patient will not, after the bleed, will not decompensate, will not have jaundice, will not have ascites, will not usually have any altered sensorium. And then you have cirrhosis, which has 20% have GI bleed, 25% of Budd-Chiari have GI bleed, and 50% of congenital hepatic fibrosis have GI bleed. Jaundice is usually absent in EHPV unless it has complicated into a portal biliopathy or any other reason. Normally, jaundice in cirrhosis is seen in 1/3. It is absent in chronic Budd-Chiari syndrome unless it's an end-stage disease, and it's absent also in congenital hepatic fibrosis. Encephalopathy may be absent in EHO. It is usually absent. 30%, again 1/3, have recurrent encephalopathy in cirrhosis. It is not present in chronic Budd-Chiari or congenital hepatic fibrosis. Ascites, very, very important. EHO does not have ascites. Very rarely, in 15%, there may be a post-bleed ascites because of hypoalbuminemia, so much of blood loss. Cirrhotics, 20% have recurrent ascites, and a massively reaccumulating ascites, rapidly reaccumulating ascites in chronic Budd-Chiari syndrome. If you had to look at the liver, normal liver span in EHO, shrunken irregular nodular in cirrhosis, enlarged or irregular in Budd-Chiari, congenital hepatic fibrosis, differential hypertrophy, and hard liver examination. Spleen is uniformly enlarged in all three conditions. It may be very, very large in EHPVO. Dilated veins are not present in EHO, not present in congenital hepatic fibrosis, but because the left branch of the umbilical vein is patent, the anterior abdominal wall veins enlarge in cirrhosis. There is a caput medusae, sometimes rarely. Anterior abdominal walls and back veins in IVC block. Investigations, LFT is usually normal in EHPVO, again, unless it's complicated by a portal biliopathy. Cirrhosis, usually abnormal. Chronic Budd-Chiari is normal until end-stage liver disease, and congenital hepatic fibrosis, everything is usually normal, except for some rise in the transaminases and very high in ALP, alkaline phosphatase. Doppler ultrasound shows a portal cavernoma or a block in EHO, irregular outline of the liver and a dilated portal vein in cirrhosis, hepatic veins and IVC block in Budd-Chiari syndrome, and an irregular outlined liver with polycystic kidneys in congenital hepatic fibrosis. Thank you for your time.